Okay. There's more people in here today. Good morning. I think it's still morning. Thank you for joining us today. Next week will mark the second anniversary of the declaration of COVID-19 as a global pandemic. And certainly looking back to March of 2020, I don't think any of us could have predicted really the magnitude of COVID-19. The pandemic has had a significant impact in terms of the burden of disease, with over 450 million cases and almost 6 million deaths worldwide. And the impacts of this virus go beyond cases and deaths. We know that COVID-19 has taken a heavy toll on many parts of our society, including mental health. COVID-19 has affected us all differently, and for many, the last 2 years have been marked with unease and uncertainty, coupled with feelings of stress and anxiety. We have also shown tremendous resilience as individuals, families, and as a province. We have followed public health advice, we have stepped up to be vaccinated, and demonstrated our willingness to put the health and well-being of others ahead of ourselves. We are slowly and surely managing our way through this pandemic, and we've said it before, we will get there. Our progress through the next phases of the pandemic may not all be linear. And although the pandemic is not over, together we will learn to live sustainably with COVID-19 as an endemic disease, knowing that there may be future waves and outbreaks. Transitions are challenging. We do not know the risk of resurgence of new variants of concern. However, we will be ready to respond. Going forward, we will continue to rely on important tools in our toolbox, including vaccines, therapeutic treatments, public health measures, robust surveillance and monitoring, and public health and healthcare infrastructure. As of 8 o'clock this morning, there are 704 new cases of COVID-19 to report, bringing our total active cases to 4,596. Over the last 7 days, we've had an average of 506 cases a day. In terms of outbreaks, there are outbreaks in 2 long-term care facilities, Garden Home and Somerset Manor. There are no outbreaks in community care facilities. As of this morning, there are 42 early learning childcare centers impacted by COVID-19. 27 centers are open, 10 are open with modified or limited services, and 5 centers are closed. As I've mentioned before, immunity following vaccine is a more robust, consistent, and predictable way to be protected than natural immunity acquired as a result of being infected with COVID-19. Getting a booster dose when you are eligible is important. Receiving an mRNA booster offers superior protection compared to 2 doses, keeping more people out of hospital and preventing deaths. There is emerging evidence that getting a booster dose also provides protection against long COVID. As of Sunday, March 6th, 97.3% of people aged 12 and over in this province have at least 1 dose, and 94.1% have 2 doses. 69.5% of children aged 5 to 11 have 1 dose, and 41% have 2 doses. Over 40,000 people aged 12 and over are eligible for their 3rd dose and have not yet received it. But 83% of those over 50 who are eligible for booster have received their booster. I've said this before, and I will repeat it. Everyone is eligible. Everyone who is eligible should receive their booster. And we do need to continue to improve the rate of vaccination among children aged 5 to 11. And there are appointments available this week. In keeping with our slow and measured approach, next week we will plan to move to step 2 of the Moving On plan. On Thursday, March 17th at 12:01 a.m., the following changes will come into effect. Personal gatherings of 20 people indoors and 50 people outdoors. Organized gatherings of up to 75% capacity, with space being maximized to allow for as much physical distancing as possible. Fitness facilities, retail, museums, casinos, and libraries up to 75% capacity. Wedding receptions, funeral receptions, and stand-up receptions of up to 100 people. Organized sport and recreation activities with a maximum of 100 participants interacting over the course of a day. And universal screening at the points of entry will continue, but we will transition to random testing of people entering PEI. I expect we will be moving to the third and final step of the Moving Forward plan on or before April 7th. There will be up-to-date information posted on the website later this week regarding the changes that will come into effect next week. In PEI, we've had much better access to COVID-19 testing compared to other provinces and territories. Given we have tested more people, it is really not accurate to compare our case rates directly with other jurisdictions. We have a much better sense of what is happening in PEI with COVID-19. We have been able to connect people at high risk to therapeutic treatments and limit severe outcomes. We know where transmission is occurring based on the case data, and we have been able to link cases. All of this information is important as we manage this wave of the pandemic. However, our testing capacity is now strained. Last week, 13,000 tests were conducted at health PI clinics, or an average of 1,850 tests per day. And that was compared to an average of 1,390 tests the week previous, and an increase of over 30%. The percent positivity in the last 7 days at testing clinics was 24.5% compared to 20.7% in the previous week. So in many ways, we are testing the right people when you see that kind of percent positivity. In the last week, just over 200 people tested positive at the points of entry, which is also an increase from the previous week. In order to ensure our testing resources are targeted appropriately, the eligibility criteria for COVID-19 testing at the health PI clinics for individuals who are close contacts will change effective immediately. Close contacts need to continue to monitor for symptoms of COVID-19. Now, you will only need to get a day 4 test if you are a close contact and live or work in a high-risk setting, such as healthcare workers, first responders, long-term care and community care residents, members of First Nations communities, correctional staff and offenders, staff and residents of shelters and transition homes, staff and residents of mental health and addiction facilities, and essential workers approved under the Test to Stay program. Close contacts without symptoms of COVID-19 who do not live or work in high-risk settings need to monitor themselves closely for symptoms. However, they do not need to get a day 4 test at a health PI clinic. For example, if my daughter is named as a close contact as a result of a positive case on her basketball team, if she is feeling well with no symptoms on day 4, she does not need to go to a health PI clinic to be tested. Or if I am positive for COVID-19 and my children, as close household contacts, feel well on day 4 and have no symptoms, they can leave isolation without testing on day 4. But if one of my family members happened to work in a healthcare setting, they would need to get tested on day 4. If you are a close contact of a positive case, a family member, a best friend who had a sleepover, and you develop symptoms, you do not need to be tested at a clinic, and it can assume you're positive for COVID-19 and isolate for 7 days if you're fully vaccinated or 10 days if not fully vaccinated. The exceptions to this are people over the age of 50 years, pregnant individuals, children less than 5 years, and those 18 years of age and older with underlying medical conditions. In other words, symptomatic close contacts of a positive case who are over the age of 50, who are pregnant, who are less than 5, not eligible to be vaccinated, who are 18 years and older with underlying medical conditions should seek testing at a health PI clinic. And this is important because of the higher risk of severe outcomes, also important because of our surveillance and our ability to make sure that people have access to treatments like the Paxlovid. Other symptomatic close contacts of positive cases do not need to seek testing and can assume they are positive. For example, my poor daughter, she's getting used in all these examples. If my daughter is positive and is isolating, and one of her brothers develops symptoms, we will assume that her brother is positive and he will isolate as a positive case for 7 days because he is vaccinated. He would not need to go get tested again. Health PI testing clinics will continue to test symptomatic individuals or those with a positive rapid antigen screening test if they present at a testing clinic. These changes reflect optimal use of our testing capacity, focusing on those at higher risk of severe outcomes so we can connect them with antiviral and monoclonal antibody therapy, and those who live, work, or access vulnerable settings to protect those who live or utilize these settings. If you have symptoms and know you had close contact with a positive case, you can assume you're positive for COVID-19. But of course, if you believe there's another reason for your symptoms, certainly the health PI will continue to test you. Dropping the required testing for asymptomatic close contacts does increase the level of risk. Approximately 88% of individuals with COVID-19 do have symptoms, so we expect to miss a small number of positive cases as a result of these changes. Once again, this is why testing capacity will be targeted to individuals who work, live, or access vulnerable settings to reduce transmission and outbreaks in these environments. Regarding children, regular rapid antigen screening for schools and early learning childcare settings will continue until the end of March, and this provides an extra layer of protection in those settings. At some point in the coming weeks, testing will be targeted only to those with symptoms and live or work in high-risk settings or who are at increased risk of severe outcomes. I know there are many families and children looking forward to March break this year. Since school reopened for in-class learning in late January, there have been additional strains and stresses on students, families, and staff. Despite the high daily case counts and widespread transmission in communities throughout the province, thanks to island families and dedicated school staff and administration, all of our schools have remained open. Your actions have made a difference. Many are ready for a break and need time to rejuvenate. I wish all families, staff, and students a restful, fun, and safe March break. For those families who plan to travel over the break, I encourage you to be vigilant and to travel as safely as possible. Wear a mask and monitor yourself for symptoms of COVID-19. If you do feel unwell, please arrange to be tested. I heard someone say earlier in the week, pack your patience as well, I think, if you're planning to travel. Children should continue to be tested using their supply of rapid antigen screening tests during the March break. We encourage students to be tested 3 times during March break as follows: Sunday, March the 13th, Friday, March 18th, and Sunday, March 20th. And of course, immediately if they get symptoms. Students and staff in grades K to 12 have been provided with enough rapid screening tests for the next 3 weeks or until the end of March, with 3 tests per week. We know that many families have an adequate supply of rapid antigen screening tests and do not need any more. For example, their child may have tested positive for COVID-19 and therefore does not need to be tested for the next few weeks. It will be helpful if students and families identify themselves as not needing additional packages of tests so they can be distributed to families who need them. When students and staff return to class on March 21st, the following changes will be in effect, and this really aligns with some of the changes with Step 2 of the Moving On plan. Cohorts in K to 9 will increase to 100 to align with the public guidance. Schools will no longer be contacting close contacts of positive cases, which they are doing for those 12 and under. Instead, everyone should be actively monitoring for symptoms, and parents will be asked to continue to report positive cases to the school. Masking will continue to be required in schools. Mask requirements in schools will change in future to be consistent with measures for the general population to wear masks in indoor public places and workplaces. In conclusion, the Moving On plan is a guide to help the province transition out of COVID-19. As we've said before, it does not mean the pandemic is over. It signals that we are changing and adapting to how we live with this virus. Together, we will remain in a state of readiness to respond to COVID-19. We'll be prepared to manage outbreaks in high-risk settings, adjust vaccine recommendations, and conduct surveillance and monitoring. There are a number of factors that enable us to transition at this time. We have a high rate of full vaccination and booster doses, although we can still, there's still people who need booster doses. We have effective pharmaceutical treatments, antivirals and monoclonal antibody therapies to mitigate the risk of hospitalization and severe outcomes in those individuals who are most at risk. The Omicron variant, although very contagious, is a less virulent strain of COVID-19. And we will continue to monitor the impact of COVID-19 and PI, including the management of outbreaks in high-risk settings. We will continue to protect those who are most at risk. We will place a priority on protecting those who are most vulnerable to severe outcomes. As we continue to navigate COVID-19, we should get vaccinated, including our booster doses when eligible, think about our own risks before going out, and make informed decisions. Follow public health measures, including wearing a proper fitting mask when in closed indoor spaces, and stay home when sick. And as we finish every press conference over the last couple of years, and as we continue our long and weary journey with COVID-19, let us continue to be patient and kind. Thank you. And I'll open it up to questions. So maybe we'll start with people in the room. Laura Meter from CBC.
Thanks. Yes, I just wanted a description of what you're seeing at testing sites and how that is playing into some of the decisions you mentioned about testing.
Hi, Laura. Well, certainly, I mean, as we just reported, we've seen a 30% increase in terms of the number of tests being performed at the testing clinics in the last week. So we know that that certainly puts strain on the testing clinics themselves, but also it's really challenging to wait to have those tests done for people who need to be tested. So. And we also mentioned that, you know, a lot of other provinces and territories have changed who they're testing. But it's been really important for us to know and have a sense of the level of circulating virus in this community. So we've been certainly making adjustments. We're always trying to keep a good handle on what is happening here. Certainly our case counts, one of the indicators that we look at, and we've talked about that previously. But cognizant of making sure we want the people who need to be tested and have good access to the testing that we have here.
You talked about point of entry changing to random. What does that mean? What can people expect?
So, I mean, we've talked about making some stepwise transitions out. So, right now, unless we're in contingency, most people are tested as they are coming into the province or returning to PEI, and those who may not be tested are offered rapid antigen tests. So after starting March 17th, it won't be everyone being tested, but there'll be random testing done, and then those who aren't tested will be offered the rapid antigen test. So you'll either be tested with the ID Now machine at the point of entry or given rapid antigen tests.
So you'll still be given the rapid test no matter what, okay?
Exactly.
And then you talked about the protecting the most vulnerable and getting extra therapies for people. I'm wondering if you could expand on the extra treatments you'll be offering people?
I think those are the treatments. Those really aren't. That's trying to make sure that we have for those who may need it, the antivirals, the Paxlovid, which we've talked about quite a bit, and the monoclonal antibody therapies. So we anticipate, I think, perhaps today or yesterday, additional doses of the Paxlovid have arrived in the province, and we have the referral process for those who may get screened or referred as potential candidates for Paxlovid, and so that will continue, and hoping as we get more antivirals into the province, we'll be able to expand that even further.
And is that happening right now?
Yeah.
Yeah,
Yes.
and
So-
how many people have been getting those?
So there have been over 153 referrals in the last month for Paxlovid, and some who may not have qualified for Paxlovid actually have then accessed the monoclonal antibody therapies, which the amount is lower that we have in the province. So we've done quite a bit previously. We've talked about this a little bit previously, Laura. But we can give further details and follow up if you want.
Curious, I know some people are dealing with a lot of isolation right now, and just, someone in your house, you might be a close contact, then a close contact again, just isolating, having to isolate over and over again, and that can be frustrating for people. Mm-hmm. I'm just looking for your comments on, will that kind of scenario continue on?
So I think the last time we were out, we really made some changes, or relatively recently made some changes in that the close contacts, if you're not in the household close contact, they're no longer isolating, they're monitoring for symptoms. So I think that has made it quite a bit easier for many people who aren't having to isolate in the same way, even if they're close contacts, if they're not household close contacts. So that was certainly a recent change, and I think but we know those close contacts can still get sick and spread COVID. So that was really one fairly big step in not having everyone isolate. We also made some announcements last time around changes around those who get consecutively positive in a household. So I think those changes were also announced previously. So, but if your question is at some point, and I would think that will be within a few weeks, if I hope that only those people who are ill will need to isolate and not other close contacts if they're feeling well.
But if you get symptoms again, you isolate again? Yeah.
If you're symptomatic,
Mm-hmm.
if you're this is why I was really trying to be careful when I put this out, because there's a whole bunch. So if you
get symptoms one week and then you get it the next week, do you isolate it? You know what I'm saying?
Well, if you've just had COVID and you're confirmed COVID 2 weeks ago, and you start to have a runny nose, it's unlikely to be COVID again. because this is all Omicron at this point in time. Now, if you were sick and you had COVID last October, you absolutely can get Omicron, and you're there's a 5.4 times increased chance that you can actually get a different variant, Omicron variant, compared to previous. So that's why once we knew that over 90% of the circulating virus was Omicron, then that's why that date has been used in some of our references online, that if you had COVID before that, you'd still need to isolate if you get sick again. But if you had Omicron 2 weeks ago, you will not need to isolate.
Yeah, because it's you're assuming, so you just treat it the same as if you had the test kind of thing. You assume you have COVID, like you talked about that, if you have the symptoms.
Yes.
Yeah.
I think we may need to clarify that afterwards, Laura, just because there's maybe multiple parts to that. We're talking about household close contacts who get symptoms, and that's within 4 days of you knowing. So if my daughter has COVID and she's tested positive for COVID and I'm isolating in the house with her and 3 days later I get symptoms, then I likely have COVID, right? But if it's 3 weeks from now, then that's not I'm not isolating with someone who has COVID. So I would want to get tested as a new case.
And my final, just why is isolation so important still if we're seeing such wide transmission?
So I'm glad you asked that. So isolation, we know that pre-symptomatic and asymptomatic people can still transmit the virus. We know that in households, from all the information we can get from our cases, that there is a lot of transmission happening within households. So if you didn't isolate, then in the 48 hours before you got symptoms, you could have infected other people. So Laura, if I find out you test positive today with COVID and your symptoms just started today, everyone you've been around over the last 48 hours, you've just exposed to COVID. And what if you went to see relatives in a nursing home or et cetera, and you took your mask down to talk to them? So that's where if you're not isolating and you go into certain settings, that's when we're concerned. So isolation means that you haven't then transmitted it to others in those last couple of days. And we've talked about this at length throughout the pandemic, the importance of isolation. So this is, I think, probably repeating what we've done. But if I have someone in my household who I know, or if I'm isolating my household and I develop symptoms in a couple of days, I haven't put anyone else at risk because it's just been me at the house, or just me in my room. But if I've been out and about, I have put others at risk over that period of time. But while I'm isolating, I am not exposing others.
Do you expect that isolation rule to remain for quite a while?
No. I mean, I think we are trying to transition our way out of this, and at some point it will be, and that's why we're looking at the risk. We balance the risk, but the people who are sick should stay home. I mean, that's where we're going to get to, and it's going to happen relatively quickly. But each step we make is one step that we're trying to make together, and but it's also why masks in certain settings are going to be important for a longer period of time.
Thanks for putting up with the person that doesn't come to these briefings.
No, it's good. No, it's good because I think those same questions are worth repeating and clarifying, because we forget. Sometimes I forget why we're doing some of these things. So, thank you for the questions. Julien, you're next on the list here.
Oh, sure. Let me change my battery. I need an extra
Okay. Julien Lecachel, Radio-Canada.
Oui, c'est moi.
Okay.
Docteur Morrison, première question pour vous. Parlons des tests, des sites de tests. Ils n'ont jamais été aussi pleins, aussi occupés. Et là, vous nous dites ce matin la stratégie du gouvernement pour faire baisser le temps d'attente et avoir moins de monde dans les files. En gros, c'est de changer les règles pour les cas contacts. Est-ce que c'est ça votre
Oui,
stratégie?
c'est ça. Ouais. Et puis, c'est plutôt pour la stratégie pour ceux qui sont les close contacts qui n'ont pas les symptômes. Vous pouvez continuer, il faut pas être testé. Et puis, vraiment, ça, toute seule, va diminuer le nombre de personnes qui doivent être testées. Sauf que si vous travaillez ou vous habitez quelque part qui sont plus à risque, si vous sentez, si vous travaillez comme infirmière au foyer de longue durée, vous devrez être testé quand même. Alors, je pense, même ça, vont essayer de diminuer le nombre de tests qu'on a aux cliniques. Mais c'est quand même important que les personnes qui ont les symptômes, qui sont 50 et plus âgées, sont moins de 5 ans, qui sont enceintes, qui sont 18 ans et plus, qui ont des conditions, il faut être testé parce que c'est dans ces cas, on peut les lier avec, pour voir si il doit avoir comme le Paxlovid ou d'autres médicaments.
Pourquoi ne pas embaucher plus de personnes dans les sites de dépistage ou pourquoi ne pas ouvrir des pop-up cliniques dans les pharmacies avec d'autres sortes de tests plutôt que de changer votre stratégie avec les cas contacts?
Alors, l'île du Prince-Édouard, comparé à toutes les autres provinces et territoires, ont vraiment déjà changé leur stratégie. On a peut-être une des meilleures sens ici à l'île du Prince-Édouard de qu'est-ce qui arrive à propos de notre cas parce qu'on avait accès aux tests. Mais avec Omicron on voit maintenant que c'est très important de continuer de regarder le nombre de personnes à l'hôpital, le nombre de outbreaks. Alors, c'est pas le seul chose qu'on regarde. On a les autres indications, on vient de parler, et plusieurs fois. Alors, on veut faire la transition et puis à un moment donné, on va vraiment faire seulement les tests à ceux qui sont malades et qui sont à risque. Alors, c'est vraiment notre moment de transition pour tout le monde.
Donc, ce n'est pas dans vos plans d'ouvrir d'autres cliniques de dépistage ou de faire des pop-up cliniques dans les pharmacies?
Non, pas à ce moment. Non, c'est de s'assurer qu'on continue de tester les personnes qui ont vraiment besoin, qui sont à risque de transmettre ou d'avoir des outcomes plus sévères.
Changeons de sujet, parlons des chiffres. Vous l'avez dit, je vais prendre la moyenne sur 7 jours qui représentent mieux les cas de COVID-19 à l'île du Prince-Édouard. Environ 500 par jour sur les 7 derniers jours. Ouais. Si je ne me trompe pas, ce chiffre n'a jamais été aussi élevé depuis le début de la pandémie.
Exactement, ouais.
Mais malgré tout, le 17 mars, on va de l'avant quand même.
Oui, j'espère que oui. Et ça, c'est le plan. À cause de vraiment les choses qu'on vient de parler, le virus Omicron, c'est pas aussi sévère que les autres vagues. On est tellement vaccinés avec la majorité des personnes qui ont des boosters, qui sont 50 ans et plus. On a le Paxlovid qui est ici. Alors, avec ces choses, on fait attention à toutes les autres indications. On a quand même le nombre de personnes à l'hôpital le plus bas dans la région atlantique quand même avec le nombre de cas. Alors, c'est pour cette raison et chaque jour, je suis tellement thankful, remercie que ça n'arrive pas l'année dernière ou même en septembre, parce que sinon, on n'avait pas le nombre de personnes vaccinées, on n'avait pas le Paxlovid, alors tellement de gens seraient malades ou pire. Et puis, alors, je sens mieux parce qu'on est dans cette position maintenant, même avec le nombre de cas.
Le 17 mars, au point d'entrée, test aléatoire pour rentrer. Ça va arriver 3 jours après que le Nouveau-Brunswick et la Nouvelle-Écosse vont enlever toutes leurs restrictions. Est-ce qu'il y a un lien? Est-ce que finalement c'est...
Non, vraiment, on a le 17 mars, c'était vraiment le step 2 pour nous. Et puis, je pense que c'est aussi important pour les points d'entrée et c'est pour l'aéroport aussi qu'on va faire c'est pas tout le monde, mais on va quand même donner les tests. Et ça va continuer jusqu'au fin de mars, 1er avril.
Comment vous voyez justement la levée de toutes les restrictions chez nos voisins, alors que nous, on va encore en avoir un peu? Est-ce que vous vous attendez à ce que les cas remontent après le 14 mars?
J'ai remarqué que le nombre de personnes à l'hôpital, je pense au Nouveau-Brunswick, a commencé hier à augmenter un peu. Alors, pour nous, on était assez... c'est pas une course. On vient de dire ça. It is not a race. Alors, on va continuer de marcher assez steady. Mais alors, pour quelques semaines, si on peut diminuer le nombre de personnes qui sont à l'hôpital ou qui sont malades, on devrait le faire. Et puis, mais tout le monde va arriver aux mêmes lignes en finale.
Ma dernière question, vous aviez parlé du 7 avril pour la levée de toutes nos restrictions. C'est toujours la date que vous avez en tête. Est-ce que cette date pourrait être rapprochée, peut arriver plus tôt en mars ou elle pourrait être reculée plus tard en avril?
Ça dépend vraiment un peu qu'est-ce qui arrive les 3 semaines qui suivent. J'espère peut-être avancer un peu, mais j'imagine qu'on resterait avec peut-être les masques dans certains environnements un peu plus longtemps que ça. Mais on va revenir ici pour confirmer tout ça après le congé de mars.
Merci.
Merci. Allison Jenkins, The Guardian.
Thank you, Dr. Morrison. Will the province be tracking these presumed positives?
For those who may, we aren't going to be tracking all the presumed positives. We certainly feel like we're going to have a good sense from surveillance of all the people we are testing, those who are 50 and above, and those 18 and above with underlying medical conditions, those less than 5, of course, anyone who's going to the hospital. And there'll be a certain amount of the testing, of course, of close contacts of those who live or work in certain settings. I know that it has been discussed, whether you put a form online and send them in. I think at this point in the pandemic, we have lots of good surveillance going on. We're still doing a lot of testing, so we may not need to do that. And I'm not sure what the compliance will be for everyone to fill in a form and send that in, but we certainly have talked about it.
Okay. And I have lots of questions that I'll save for later, but what's going to happen to the testing stations after April 7th?
So I think the testing clinics or the point of entry.
Both.
Okay. Well, I think that there's lots of discussion about what will happen in general with some of the testing machines and where they may be placed after they're not needed in the points of entry in the same way. I think there'll still likely be testing at points of entry for those who want to be tested, at least for part of April. And also people who may want to pick up random tests will still be available at our airport and our at the Confederation Bridge. Even if it's not required at that point in time. And then there are different options being looked at in conjunction with Health PI for where those machines might best be used, and if they're in certain parts of the province, in certain locations, and knowing that testing for those who may need antivirals, for those who are sick, will still need to continue into the future. So I think those are discussions that we're having, and I know that we have a testing meeting. I think it's tomorrow as well. So I think those are the things that we talk about every week, trying to figure out when and how those will be used.
Okay, thank you very much.
Okay, you're welcome. I think, John, do you have any question?
Yeah, what percentage of people who test positive for COVID-19 are developing long COVID? And what are the symptoms you're seeing when it comes to long COVID?
Okay, so thank you, John. We actually talked a little bit about long COVID maybe last time too, but I guess a couple of comments about long COVID that we actually, and we've sent information out to all our providers, our physicians and nurse practitioners about the actual World Health Organization case definition of long COVID and or post-COVID-19 condition. And a lot of what we know about long COVID or post-COVID condition is based on information prior to Omicron. And with Omicron being a real sort of different strain, and actually the virus looking a little different, the evidence is still coming on what Omicron, what impact Omicron will have, or what percentage of people will go on to get long COVID. But based on the information, sort of mainly pre-Omicron, that there will be a medium long-term impacts on many Canadians, including Islanders. And this is some of the information out of the Public Health Agency that, 50% of individuals who've had COVID-19, again, this is pre-Omicron, who've had COVID-19 reported the presence of one or more symptoms 12 weeks after diagnosis. And about 58% of children had one or more symptoms 4 weeks or more after their initial COVID-19 infection. So that's still, those numbers, again, what they mean in the post-Omicron is not quite clear, but I think we need to learn more about it. And we've said that here as well. Stats Can is going to be conducting a survey on post-COVID-19 condition, and that will include a representative sample from PEI. So we'll be certainly, and I think that survey is expected to launch in April. So we'll be looking at that data as well for our province. And we're going to continue to work at doing the best or exploring options to do surveillance of the post-COVID condition with our providers here.
Thank you.
You're welcome. And I think there may be somebody on, or some folks on the phone.
Pierre, Radio Canada. Pierre, Radio Canada. Louise Martin, CBC. Oh, hi, good afternoon. You can hear me okay?
Yes.
A little bit echoey on my end, but can you just update what the current hospitalizations are, Dr. Morrison? I don't think you mentioned in the beginning of the briefing.
No, hi, Louise. I think they were reported yesterday on the website. I believe it was a total of 9 and hospitalization, 2 who were being treated for COVID. I don't have.
So it hasn't been updated?
That hasn't. I don't have new numbers this morning, but they'll be updated again tomorrow.
Thank you.
Okay.
On the limiting testing now and the new rules around close contact, is it not important to have an official test result in your medical file, particularly if there are long-term negative effects? You need to prove that you were positive at one point. And I'm thinking as well for people who have to travel, particularly for work, who may not be able to without that confirmed positive on their record.
So that's why, Louisa, it's if people do have symptoms and want to be tested, they absolutely will be able to be tested. It's just that it's not a requirement. And as you mentioned, some people will want to make sure that they have that official documentation that's linked into their healthcare record. But others may not need that or want that, and so it's really that requirement is not there, and especially because the biggest part of this is the close contacts who do not have symptoms. And we know that there are a lot of close contacts on hockey teams, close contacts of family members. I think we could all name some or have been some ourselves, and that have waited for those test results, but they feel well and they are testing negative at the clinic.
Okay, thanks for clarifying that. When will you reduce the length of isolation? And a lot of other places are already at 5 days. When will PEI make that change?
For those who have COVID, we actually know that people can still really transmit virus up to 10 days, but most of that spread can happen within 7 days. We know some provinces have gone to 5 days. The CDC actually, I think one of the last press conferences I was here, someone asked me, were we thinking... or maybe it was in a email question, the concern around, some places that were at 5 days wanting to go back to 7 days, and wanting to make sure that we didn't move. So I think we always have continued to look at our period of isolation, as you know. 14 days, 10 days, 7 days if you're fully vaccinated, if you're ill. So if we can make that adjustment and people are feeling well, we may do that, but certainly not today. But we continue to look at the evidence.
I understand you said you're not comparing the numbers with other places right now. But really, this isn't comparing PEI to other provinces. This is really comparing PEI with itself, and the data shows numbers we've just never seen before. So what is being actively done to bring those numbers down? It feels to a lot of people counterintuitive when those numbers are going up that we're going down on restrictions.
Well, I mean, I think, and I certainly understand some of that. It's sometimes it's hard for me. It's hard for the team as well. But I think we've talked about it, and maybe I said it in French to Julien. I mean, I think we have to think Omicron is different. It doesn't have the same virulence as we've seen with other strains. We have a well-vaccinated population and a well-boosted population in those, especially 50 years of age and older, where you have the most risk of severe outcomes. We have access to antivirals in a way that we didn't have. And I said this in French, so I'll repeat it in English. I am thankful every day that we are having this kind of situation now, and that we didn't have it this time last year, or didn't have it in the fall, where we were not able to protect people in the same way without vaccine, without boosters, without antivirals. And this is a different kind of a strain. So I think that's part of the answer to your question, Louise. This is certainly different than what we've had over the last couple of years in terms of what's circulating. Certainly, we're all very aware that there's virus circulating, and some of these measures and some of the decisions we make, we will have to continue to think about until that level of circulating virus is a lot lower than it is now. And there's levels of circulating virus similar in other provinces and territories, but they are not doing the same, and they have not been able to do the same kind of testing we've had here because they have not had the access.
But how do you explain that to people who with underlying medical conditions or with children under the age of 5? You know, when we're told over and over in healthcare, prevention is critical for any ailment. And so it feels like that would be a reaction, you know, treating the COVID as opposed to preventing it.
Well, I mean, I think that's why we have masks in place. We have rapid testing for those in early child care and schools. We are still have restrictions in place that will probably be in place here, as Julienne's pointed out, longer than our neighbors in New Brunswick and Nova Scotia and Newfoundland. Because I do think they're important. We know public health measures work. We know all these layers of protection are helpful. It's also why those who are less than 5 who have symptoms, we are not including them in people who might not need to go get tested. It's important they get tested because we really want to keep track of that any severe outcomes in that age category. So we are, I think, trying to do all those layers of protection, and for those who are immunocompromised as well, or may not be able to be vaccinated, trying to look out for each other. We know that the decisions that we make, we need to be respectful and cautious, look out for each other, and that includes our little children who cannot be vaccinated. It includes those who may be older or who are immunocompromised. We need to do our own risk assessment. How many people are we with? You know, where are we going? Are we going to wear our mask? And we've talked about it before, and I think maybe last week you were getting at it with one of your questions, that we also have to balance because this is really hard on everyone. So we're going to try to balance and keep everyone as safe as possible as we walk out of this pandemic and not... the pandemic is not going to be over all of a sudden on any certain date, but we are going to be entering a very different phase of it. And it's how we're getting from here to that different phase, knowing that the virus is circulating, but as we said, that we still need to be cautious. Testing will continue to be important from a surveillance point of view, and monitoring. But I think we're at a very challenging time for us in PEI, but I think we're going to get there. As I said to Julianne, we're all going to get to the same point. We just may not all get there on the same day, but we'll continue to make this transition.
It would be nice if there was an actual end date to all this. Can you just quickly clarify for me what people who have already had COVID and are close contacts and experience symptoms should do? Just sort of maybe a little bit of confusion if you've already had COVID and then later on are identified as a close contact, do you have to get tested or isolate?
No.
And you have symptoms.
So if, well, I mean, in general, even if you don't have COVID, if you have symptoms, you likely are sick with something, so you should stay home from work or school, because otherwise you'll spread another respiratory virus, which we don't want to do. So, but if you've had COVID within the last 90 days and you do not need to go get tested for COVID, and the isolation requirements are not the same as a close contact if you've already had COVID within the last 90 days. And I'm talking about particularly since December 15th. And I think that information is on the website.
Perfect. Thanks so much for that. I appreciate it. Have a great afternoon.
Okay, thanks, Louise.
Teresa Wright. Hi there. Thank you for taking our questions. Just picking up on the answers you were giving to the questions about essentially justifying why you're relaxing restrictions, given that we've never seen case numbers as high as this. How much is the current moving on plan based on the fact that 90% of the cases in PEI are Omicron, and how might this change if we see a new variant, especially as we relax travel restrictions and see people possibly traveling for March break and therefore risk another variant being brought to the island?
Hi, Teresa. So a couple of things. One, I think your question highlights why ongoing surveillance and testing is really going to be important well after the moving on plan we've gone through those steps, because whether that's in April or May, monitoring for new variants, level of disease, and severe outcomes will continue to be important. And I know our epidemiologists are always thinking about that as well. So I think that's why making sure that we do the testing for certain people and in certain settings will continue to be really key. I know we've heard others report here as well that on nationally that after March break is going to be really a time where everyone should be paying attention. It's also why we want to make sure that we've outlined a testing schedule for children to test prior to going back to school after March break, and also continuing that testing for after March break, so that we can monitor what is going on from a disease perspective, and knowing that people will be traveling and socializing a little differently over March break. So I agree with you, Teresa, that monitoring for any future variants will be really important. It's part of what we mentioned here, that we will be prepared for future outbreaks, for future surges, and that interpandemic time, which we will get to, will really be important, so that we'll continue to monitor that. And this COVID may become more seasonal, like influenza. We may see that happen, and but we know even with influenza there are different strains, and that happen every year, and that's why the vaccine sometimes has different strains in it that are covered. So. Those are the things that we'll continue to work on across the country and across the world as they look at what happens with Omicron and COVID.
PEI has a high rate of vaccination, as you've talked about a lot, which is likely why more people aren't ending up in hospital or having severe outcomes. But for those who are at high risk of getting seriously, if not fatally ill, if they get this virus, the current outbreak presents a serious risk to their lives and long-term health. How are PEI's current COVID-19 measures and the lifting of restrictions that you're announcing today, how are those things protecting the vulnerable people of the island?
Well, I think we're not so much easing restrictions today, Teresa, just for clarification. We're doing some changes to testing of those and making it really, making sure that testing is directed to those who are most at risk of severe outcomes, because we don't want them not going to get tested because there are too many people certainly in lineup. One of the things that we're doing here is, and I may have mentioned it before, is we are probably the only place in the country that is still trying to call each of our positive cases. And in doing so, and especially our cases who may get flagged or referred, who are 50 years of age and older, or those with underlying health conditions, and it's because of that, we are able to consider referrals for Paxlovid and for antivirals or monoclonal antibody therapy in a way probably that other provinces aren't able to do so at this point in time. And I think that's one of the things that's been very important for us. And if over the last month, if Paxlovid has prevented a certain number of people from going into hospital, isn't that great? Because that has reduced their chances of more severe illness and help preserve our health system capacity. So those are things that we continue, Teresa, to think are important. I think we still have access to vaccine. We still encourage those who haven't been boosted to do so. We know that 2 vaccines can help reduce your chance of hospitalization, but and when you look at the national data, the risk for those who are boosted to end up in hospital is still much, much lower than those who are unvaccinated, and also a reduced chance even versus 2 doses versus 3 doses. So we encourage to do that. And we have masks in place in our indoor settings. We are not announcing any changes with that, Teresa. We continue to talk about the importance of physical distancing, staying home when you're ill, some of the things we've been talking about, I'm sure for some of you ad nauseum for 2 years, but still remain really important.
If you had a family member who was immune compromised or at risk of serious illness, would you feel safe taking them out and about in PEI today, given the current situation with case numbers?
So that's a really good question, because how do you balance just when people are wanting to do other things, but when we know how much disease is circulating? I would, and I think about this even with my mother, who definitely doesn't want me to tell her age in this setting. But, choices about making sure that we would go places where she's able to wear a mask, not feel like she's in an environment where there are a lot of people that she is not comfortable with. So some of it's that personal risk assessment. Where are you going? Who are you going with? How many people will be there? Are they vaccinated? Do they have their booster? And balancing that. So are you going to an environment where they're tested frequently? Are they being screened? So, Teresa, I think those are a long way of saying I would be looking at what the setting is, who's going to be there, and trying to do that personal risk assessment, but also for those in my family who may be at higher risk of severe outcomes. But also trusting that we have a high rate of vaccination here, and that we have a system that I know if we needed to, for those who need it, could access some antivirals, which might help.
I guess I'm just trying to get a sense of what your comfort level is with the risk level for those people who are at high risk. And we're not just talking about older people. There's lots of people, and there's the people who are family members who therefore are going to be close contacts of those people who are all falling into the basket that we're talking about here. So, and I know you mentioned earlier that the pandemic has been really hard on people and the restrictions and so on. Mm-hmm. But have we got to the point where we're just so fed up with restrictions that we aren't considering what moving on means for those people who are at serious risk of complications from this virus?
Teresa, I think I've tried to address that in one of the other questions, that I think we're not, we're trying to think about everyone, and we're trying to make sure that we are respectful of those who are not, who are at higher risk. And I think because we can't have some people move on and not everyone together. And we have looked out for each other throughout this whole pandemic. We want to continue to do that. And so it is, but risk is a very challenging, I know you know this and you're able to write about it very well, but risk is challenging in that it depends on a lot of individual factors. It depends on setting factors and what decisions you're making and in which environment. And not everyone will have the same risk tolerance. And that's why at population level, we have been making decisions throughout this pandemic to try to keep at a population level people as safe as possible and providing layers of protection. And sometimes those have come with challenges that individuals don't always understand or have found those difficult. But those are the decisions that we've tried to make, knowing that there's always an element where there's a risk assessment. You mentioned that it's not always older people. Of course, there's the little young people who aren't able to be vaccinated at this point in time. And again, thankfully, we're dealing with Omicron as opposed to one of the earlier variants in terms of the severe outcomes and the relative severity of this virus compared to others.
Okay, thank you.
You're welcome, Teresa.
Cody McCacherin, The Guardian.
Hi, Dr. Morrison. I'm hearing from people who are accessing our testing sites across the island who are being tested using various swabbing methods. So it seems like no visit's the same for some. Some testing sites are using just a nasal swab. Some are doing full throat and nasal swab. And I'm wondering, have we seen any kind of accuracy discrepancies between these testing methods? And if so, what have they been? Have they been one is showing more negatives or one is showing more positives, or has there been none?
Well, hi, Cody. So it's one of the discussions, and we've raised that question with the lab and the testing clinics. As you mentioned, there's the nasopharyngeal or the NP swab. There's mid-turbinate. And then there's the nasal swab. The nasal swab tends to be the one that is used at our points of entry. Because of who is swabbing, and they are not always, for instance, nurses at the points of entry. So that's why sometimes there's test differences. We still, for instance, for those who are arriving who test positive at our point of entry, because it's a nasal swab, and we want to make sure that that the sensitivity and specificity of the test is more accurate. We actually have those folks get a second test to make sure that it's more accurate. So we know that because we're watching that sensitivity of that test, and know that when the prevalence of testing or the percent positivity at our point of entry went down, it means that the accuracy of the test, we'd be worried about some of that, the accuracy, so we then now have those confirmed. It also makes a difference if you're symptomatic or not symptomatic and what that test is done. There's no test, and I think I may have said it last time, there's no test that's 100%, and we know that. But certainly trying to make sure, we have a lot of people doing testing, and we have different types of tests being used. But I think most people are being trained to do the most appropriate test for the person who's in front of them at the setting that they're doing. We've talked about the fact that PCR tests are still the most accurate. Those are the nasopharyngeal PCR tests that are used primarily used in different places, but would be used in long-term care settings, where that accuracy is really key in terms of knowing what might be happening if they're symptomatic or in an outbreak situation. So long answer, Cody, to say we continue to look at the tests, understanding that they may not all be administered in exactly the same way by the same person, but I know they try to do the best they can with the different machines. And recognizing that a molecular ID now machine is more sensitive than the rapid antigen tests. But all of the test results also depend on the prevalence of the circulating virus, which is one more complicating factor in there.
Now, kind of speaking on that, I spoke to a person who was announced as a close contact to their partner who had COVID. And when they went to get tested their first time at one of our testing sites, it came up negative. However, maybe an hour later when they got home, they did a rapid test using, nasal and throat swab. It came up positive. However, when they went back to the testing site, it was negative. And then finally, a third time, it finally came up positive. I'm wondering, is that sort of common? Is that sort of what we're seeing? And if so, what would cause that delay in getting that positive from the actual PCR tests being done?
Well, I mean, I think everyone's different in terms of the amount of basically virus when they're exposed to it through, let's say, your nose. It makes copies of the virus, and so how many copies are being made is different for everyone, and it also depends on your vaccine status. And I mean, we tend to see those who are vaccinated when they're exposed and they to COVID, they get an infectious period that is not quite as wide. It tends to go up, but it comes down a little bit faster. So their period of time when they're at the most infectious is not quite as spread out as those who are not vaccinated. So it depends on, I think, on the on how the test was done, on the test was done, when during the symptoms it was done. And when we look at how many tests, and I think, how many tests we've done last week, then there's going to be some examples, as you point out, that they don't get the same result the first time, but maybe we'll get it after repeated tests. And that's why the importance, if you have symptoms, don't go to work, and make sure you're wearing your mask. We look at how many point of care tests that have been done. We've done over 250,000 PCR tests, and those are the PCR tests alone. And I think we talked about. I think we did close to probably 10,000 rapid tests, or the ID Now rapid tests at the points of entry in the last week. So that's significant numbers of tests one was for a week, one's a lot longer, but we're doing a lot of tests within a certain small period of time, so it's not surprising that there'll be some examples where there may be some inconsistencies, but people certainly in general, if they have symptoms, stay home and repeat the test if the result is negative the first time and they still have symptoms.
So you kind of explained, all the intricacies and the complications that come with testing and how there's many differences compared to even the person who's getting tested. I'm wondering, basing all of that, or looking at all of that, how can someone be confident that they're actually walking away with a negative test, say if there's asymptomatic, and be confident that they're actually not positive?
Well, what you're talking about, Cody, there is what we call the negative predictive value. And so Dr. Cameron, who's one of our epidemiologists, she actually did her whole PhD on testing predictive values and testing positive predictive values. So she is my go-to person when we talk about a lot of these tests. And I know she works with a lab, and that negative predictive value actually is also influenced by the amount of virus circulating. So our confidence in a negative test can change depending on how much virus is circulating in the community, and also if you're symptomatic or not. So if I don't have symptoms and I would not have a lot of confidence in an antigen test alone if I didn't have symptoms. But if I do not have symptoms and had a molecular test at the clinic, I would be confident it was a negative test. But if the next day I got symptoms, I would want to get retested.
All right, thank you.
You're welcome. I think that might be finally it for the briefing. So anyway, thank you all very much.